Hi, here I am Dr. Zell, and the topic is pyloric stenosis. Pyloric stenosis is an idiopathic thickening, that is hypertrophy and hyperplasia of pyloric musculature, that is particularly the circular muscle fibers, which then results in progressive gastric outlet obstruction. Pyloric stenosis is relatively common. The incidence of pyloric stenosis is 2 to 4 per 1000 live births, and there is also seen male predilation with ratio male to female 4:1. The risk factors are like being the firstborn, that is 30%, maternal history of pyloric stenosis, cesarean section deliveries, bottle feeding. Pyloric stenosis has been known with certain associations such as Turner syndrome, tracheoesophageal fistula, esophageal atresia, and trisomy 18. Pyloric stenosis present with certain clinical presentations that may start as early as 3 weeks, and the usual onset is 2 to 8 weeks of the age. The hallmark presentation is with non-bilious projectile vomiting, that is, forcible frequent episodes of non-bilious coffee ground vomiting, and usually occurs 30 to 60 minutes after the feeding. Usually present with certain signs such as hypertrophied pylorus, which can be palpated as an olive-sized mass in the right upper quadrant and visible gastric peristaltic veins in the left lower quadrant. The general signs and symptoms in case of pyloric stenosis are likely the weight loss, the persistent hunger, lethargy, constipation, and sometimes diarrhea. While on physical examination, a succussion splash is audible, which is heard hours after the last meal. In this picture, here you can see visible peristalsis in the abdomen and projectile non-bilious vomiting and circular muscle thickening. Whereas in this picture, here you can see the olive-sized mass, that is hypertrophied pylorus. In this picture, here you can see an infant beside projectile vomiting and a kidney tray carrying the non-bilious coffee ground vomit. While in this picture here you can see an infant with weight loss, and you can also see an olive-sized mass in the right upper quadrant. Pyloric stenosis is the result of both the hyperplasia and hypertrophy of the pyloric circular muscle fibers. The pathogenesis of this is not yet understood. There are 4 main theories, such as immunohistochemical abnormalities, genetic abnormalities, infectious causes, hyperacidity theory, and there is also an emerging new theories that due to abnormal innervation of the muscular fibers leads to the failure of relaxation of the pyloric muscle and increased synthesis of growth factors. The diagnosis of pyloric stenosis can be carried out through blood reports, which may show the decrease in electrolytes such as decrease in potassium, decrease in chloride, and may present with metabolic alkalosis. Findings on plain X-ray abdomen are non-specific but may show distended stomach with upper abdominal gas bubble in stomach and with minimal distal intestinal gases. Barium study is the most accurate diagnostic test in upper GI barium series. This is caterpillar sign. Here you can see the stomach appear distended, air-filled and with a wave-like contours resembling the appearance of a caterpillar. This occurs from the gastric contractions against a hypertrophied obstructing pylorus. Here you can see sting sign. Sting-like appearance of a contrast-filled bowel loops caused by its severe narrowing. Elongated pylorus and a narrowed lumen with only small barium streaks passing through. Here you can see the shoulder sign, that is bulging of the hypertrophied pylorus muscle into the lumen of antrum. Here you can see the filling defect in the antrum due to inward displacement of the muscle. Here you can see the mushroom sign, that's also called umbrella sign. Here you can see impression is made by hypertrophic pylorus on the duodenal cap. Here you can see double tract sign, also called railroad tract sign. Here you can see the barium is outlining the crowded mucosal folds as parallel lines. And here you can see excess mucosa is leading to the formation of two barium columns. Here you can see beak sign, that is actually a bulge in the distal antrum. Ultrasonography is the best initial test. On abdominal ultrasonography, we can see the pylorus thickening and we get measurements. Ultrasonography is the modality of choice because of its advantages over barium, that it directly visualizes the pyloric muscle and there is no ionization radiation. The appearance of hypertrophied muscle is hypoechoic and the central mucosa is hyperechoic. Normal values of pyloric is that length it is less than 15 millimeters. The single muscle thickness is less than 3 millimeters and pyloric width is less than 7 millimeters. On ultrasonography, here you can see a cervix sign. Here you can see indentation of the pylorus into fluid-filled antrum. In this ultrasonograph, here you can see antral nipple sign. Here you can see pyloric mucosa that is protruding into the gastric antrum. In this ultrasonograph, here you can see a target sign. It is sign seems due to the hypertrophied hypoechoic muscle surrounding the hyperechoic mucosa. Please subscribe my channel for more videos and updates.